Three, two, one. Sir, Dr. Sanket, over to you, sir. You can start.
Thank you. Good evening, everyone. I welcome one and all to ProCare AHT's MedLive CMEs, a scientific platform provided by McLeod's Pharmaceuticals. I am Dr. Sanket Niwale, representing medical affairs at McLeod's. And today we are here to discuss on the topic, bridging the gap in diabetes management with or without CV risk. Before we start, I would just like to give you a quick introduction on the company. McLeod's is equipped with an experience spanning across 3 decades, has emerged as a global force with a dedicated team of around 14,798 professionally qualified employees worldwide and state-of-the-art manufacturing and R&D setup. We are one of the fastest growing pharmaceutical company in India. With a growing presence in more than 80 countries, McLeod's is now gearing to be a pace setter for the world healthcare. Today, we have 2 speakers and 2 chairpersons for today's session. The speakers we have is Dr. Prakash Kurmi would be chairing the session of Dr. Tiven Marva, and Dr. Manoj Vitlani would be chairing the session of Dr. Jayesh Prajapati sir. Let me quickly introduce today's faculties for everyone. To start with Dr. Manoj Vitlani, he has completed his post-graduation in medicine from a renowned institute based in Gujarat. He also has done his postgraduate diploma in diabetes mellitus from Middlesex University, UK, and pursued research on diabetes, hypertension, and lipids. He has participated in many national and international research in the field of diabetology, hypertension, and lipids. He holds special interest in diabetes, thyroid diseases, infectious diseases, hypertension, geriatrics, and preventive medicine. He is an academic life member of Research Society for Study of Diabetes in India, life member of Association of Physicians of India and Association of Physicians of Gujarat, past president of Association of Physicians of Ahmedabad. He is currently working as a senior consultant physician and diabetologist with HCG Hospital, Ahmedabad for the last 22 years. The next person I'm going to introduce would be Dr. Prakash Kurmi. Dr. Prakash Kurmi has done his MBBS from NHL Municipal Medical College, Ahmedabad. He's done his MD Medicine from KM School of Post-Graduation, Ahmedabad. He's done his medicine from, he has done his fellowship in diabetes in 2009, that is FIDM CMC Vellore. He is a consulting physician, cardiologist, and diabetologist at Shivam Hospital, Ahmedabad. He is also a visiting physician at Siddhivinayak Hospital, Maninagar, Ahmedabad. He's also a visiting physician at Sardar Patel Hospital, Maninagar at Ahmedabad. And he has done an immense research. He has started with IMPACT, a study for insulin in 2008 until 2010. TRACK study for eradication of Plasmodium vivax by GSK, and also control of hypertension by telmisartan study, a phase 4, and olmesartan study, another phase 4 trial. He has done his research reduction of HbA1c by insulin analog in diabetes. Next, I'm going to introduce would be Dr. Tiven Marva, who would be our first speaker today. Dr. Tiven Marva has done his MBBS in MD Medicine from Gujarat University. He has done 4 years of training in the subject of endocrinology, diabetes, and nutrition in the Central Hospital of Region and University of Grenoble in France, where he has secured DIS degree with distinction and secured the first rank in the French University. He has participated in several national and international conferences, received AMA Award from Chief Minister of Gujarat for Medical Excellence on 97th Annual Day. He has co-authored in RSSDI textbook of diabetes and the 3rd edition, involved in many research projects in the field of diabetes and thyroid, and presented several papers in the national and international journals. Past president of Association of Physicians of Ahmedabad, currently involved in many research projects in field of diabetes, is the director La Nobre Diabetes, Thyroid, and Endocrine Center, a holistic center for the care of diabetes, thyroid, and other hormonal disorders. He is a practicing endocrinologist and diabetologist in the Ahmedabad city and honorary of associate professor of endocrinology, SVP Hospital, Ahmedabad, mentor and teacher for postgraduate doctors of medicine in Seth VS Hospital. We have the second speaker, Dr. Jayesh S. Prajapati, who has a vast experience of coronary angioplasty, stenting, primary angioplasty, primary valvuloplasties, pacemakers, including ICDs, biventricular pacemaker, and pediatric interventions like PDA, ASD closures, etc. He was invited as a faculty at national and international conferences like CAD, AICT, EuroPCR, TCT, and TCT Asia Pacific. He has presented various papers and interventional cases at national and international conferences like AICT, EuroPCR, Washington, USA. He was a co-investigator of various drug and interventional stent trials like the COSTAR and SIMPLE2. He is a principal investigator in PEATCH FNE biometrics registry. He has also research publications in national and international journals. He is also actively interested in taking lectures at various IMA and physician associations. He has also worked as an international scholar at Cleveland Clinic Foundation, Cleveland, Ohio, US in 2002. He is presently working as a professor and head of cardiology department at BJ Medical College, UN Mehta Institute of Cardiology and Research Center, Civil Hospital, Ahmedabad. He is also working as a director, cath lab, and senior interventional cardiologist at Apollo Hospitals, Ahmedabad. Without any further ado, I would request Dr. Tiven Marwa sir to start his session. Dr. Marwa, over to you. So you have been muted, sir. I request you to unmute yourself.
Okay. Am I audible now?
Yes, sir. Clear and audible.
Okay.
You can share your slides, sir.
Sharing the slide.
So we can see your slides. Sorry, we can see your screen, sir. So before you start your session, I would request Dr. Prakash Kurmi, sir, if you can do a bit of context setting for the session, sir.
Yeah. Hello, I am audible?
Yes, sir.
Yes. Good evening, all the friends. And I think we are a little bit late and we all are eagerly waiting for Dr. Tiven Marwa sir to give his talk on this today's topic. And I would like to say that dapagliflozin has definitely made the work of all the diabetologists, endocrinologists, and physicians very easy in day-to-day practice, because so many advantage we are seeing with use of the dapagliflozin. And in nowadays, so many companies, they are coming with very cheaper price. So it is very easy for us to manage the diabetics, particularly in the Indian scenario where the patients are almost type 2 diabetics and obese. So many advantage we are seeing with the day-to-day use of the dapagliflozin. I think more detail will be given by Dr. Tiven Marwa sir. Thank you.
Sanket, there is an issue. Can you run the slides? Is it possible?
So you want me to share the slides for you, sir?
Yes.
Sure, sir. So is the slides visible now, sir?
Yeah. Okay. So can we start now?
So over to you.
Okay. First of all, I'm thankful to MacLeod's, and also I'm extremely thankful to my dear colleagues from Ahmedabad, Dr. Manoj Vitlani, Dr. Prakash Kurmi, and my co-speaker, Dr. Jayesh Prajapati, for organizing this webinar and share some important aspects of dapagliflozin and particularly SGLT2 inhibitors for diabetes management. Can I have the next slide, please? As we know that diabetes is increasing enormously in the world, and particularly India has become the diabetes capital of the world. And this disease is not a very simple disease. It carries lots of problems. Cardiovascular disease is very much prevalent. People die of heart problems. There are also microvascular and macrovascular complications. And there is overall 6 years reduction in the lifespan of an individual if he or she catches diabetes. So this is a very, very important chronic disease which we are managing nowadays. And since India is having large number of diabetic patients, there is a lot of burden both for the physician as well as the society and the government for treating this disease. Can I have the next slide? Well, this is a very busy slide, but it shows what is the interplay between diabetes and cardiovascular disease. Both this disease, they start from the common soil. There are many common phenomena like insulin resistance, obesity, high blood pressure, sedentary lifestyle, dyslipidemia. So both these conditions have the same roots, and one aggravates the other. And diabetes causes lots of problems at the level of heart, not only coronary artery disease, but also there is involvement of the pump, and eventually patient leads to heart failure. And if not treated appropriately, diabetes becomes one of the reasons for cardiovascular death in a diabetic patient. Next, please. So this is a very famous slide. There are several phenomena which are responsible for hyperglycemia, which we call ominous octet, and several organs they participate, and we have seen these slides a number of times. So without wasting much time, I would like to go to the next slide. And this is very, very important that we are having different anti-diabetic agents to treat diabetes, and they all have, they are working to reduce A1C. But most importantly, we are more impressed by what are this impact on cardiovascular disease, because cardiovascular disease are mainly causing morbidity and mortality. So if we are having agents which can control diabetes as well as cardiovascular disease, they will be enormously useful. So all these different anti-diabetic agents, they are having different impact on cardiovascular morbidity and mortality. Sulfonylureas, they don't increase CV risk, at least the modern sulfonylureas, as it has been shown in the Carmelina study and also Origin study. Meglinetide, there are no CV outcome trial. Metformin, there was only UKPDS data which showed that it's a neutral or maybe beneficial. Pioglitazone, it increases edema, heart failure. DP4 inhibitors are neutral. Saxag can increase heart failure, which has been shown in the Sevedimi study. And GLP-1, although they are shown to reduce atherosclerosis, but unfortunately, they can also increase heart rate, which can be detrimental to some patients. Lastly, alpha-glucoside inhibitors, although there is only one study, STOP NIDDM, which did show that there are some cardiovascular benefits, but there is no clear-cut CV outcome trial, and that study, STOP NIDDM, was done in pre-diabetic subjects. Next, please. So we need to have molecules which can have both, impact on diabetes as well as cardiovascular disease with evidence. And next, please. And that several guidelines have shown the position. Next, please. What are the place for different oral anti-diabetic agents? And it has shown that we have not to just see the diabetes of an individual, but we have to see what other comorbidity person is having, particularly the end organ damages. And we have to see whether person is suffering from atherosclerocardiovascular disease, or there is an element of CKD. The new 2021 guidelines have even discriminated heart failure and CKD separately, so that if there is heart failure which is predominant, we have to use SGLT2 inhibitor. So in nutshell, so far we were focusing only on glucose or glucocentric approach or HbA1c centric approach. Now we are approaching a multi-organ and diseases of an individual, so as to give longevity and also good quality of life. So we have not to just see A1C, but we have to see what are the involvement of the other organs and decide therapy accordingly. And what does this guideline suggest? That if there is heart failure or CKD is predominant, we have to use SGLT2 inhibitor. If there is atherosclerotic cardiovascular disease, we can either use SGLT2 or GLP-1 agonist. And if there are other regions, we can use other molecules depending upon what is you are aiming at. Next, please. So there is lots of importance and thirst nowadays on SGLT2 inhibitor. Can I have the next slide? Because there is same thing which is spoken by ESP as well as ADA and RSDI. Next, please. So if there is a predominant ASCVD, we have to prefer either GLP-1 agonist or SGLT2. Next, please.
Sir, I think I'm already on the next. Okay, now you can see it.
Yeah, it is still the same. Next, please.
Okay.
Yes, so ACC guideline, there are even newer guidelines which suggest that if there is a even doubt about cardiovascular disease, you start as a first line monotherapy SGLT2 inhibitor in lieu of metformin. Next, please. So several guidelines have suggested the role of SGLT2 inhibitors, and it is not only for good control of diabetes, but also control of other comorbidities which a diabetic person can have. And kidney has become a very important therapeutic target. And since this drug is not only working to improve diabetes, but also it can improve kidney disease, prevent kidney disease, this can be a good drug to choose to prevent renal disease in a diabetic patient. So there are already cardiovascular benefit. There are also good anti-diabetic efficacy, and on top of this, it also works on renal issues. So SGLT2 inhibitors, they are not only anti-diabetic drugs, but they also have work on other organs, and they work even independent of glycemic control. Next, please. So how these kidneys have become so important in the glucose homeostasis. These are the very basic things about the involvement of kidney in diabetes management. As we know that kidney is an organ just like liver, which produces glucose when it is required, and also it has to take glucose to satisfy its own energy needs. And lastly, the loss of glucose which comes out of the urine. If it touches the threshold of 180, and there's a higher mechanism of reabsorption of glucose in a diabetic patient because of the upgradation of SGLT2 receptor. So kidney plays a very, very important role in glucose homeostasis through these three different mechanisms. Next, please. And next, please. I think these are all basic slides, and in the interest of time, I would skip some of this slide. Next, please. Yes, next. So how does SGLT2 inhibitor they work? They reduce glucose, they reduce body weight, they reduce blood pressure, they also reduce plasma uric acid, and they reduce glomerular hyperfiltration. And by all the different mechanisms, they provide benefit not only on diabetes, but also multiple mechanism or metabolic abnormality which a diabetic person can have. Next, please. So there is a cardioprotection, there is a nephroprotection. Dr. Jayesh Prajapati is going to speak on this, so I would just focus on metabolic aspect and renal aspect. How does it have the renal protective effect? It reduces intraglomerular pressure, it reduces blood pressure, and this is how it reduces progression to CKD. Next, please. Yes, there are. It has been shown that all these three SGLT2 inhibitors, they are working on different mechanisms which protect heart and kidneys. Some of the mechanisms are very common, and that's why it is called that it's a class effect rather than drug specific effect. Next, please. This is how the journey of SGLT2 inhibitor started. First time Cana was launched in 2013. 14 showed the rise of DAPA, and then EMPA came in August, and now we are going to see the other SGLT2 inhibitor like etroglyphlogen, which is still not available in India. But these three molecules and now REMO, but the medicine or the molecules which are having evidence, they are Cana, DAPA, and EMPA, and all three are profusely available in our country and used by all diabetologists, internists, and physicians to treat and benefit many of our patients. Next, please. Now let's focus on DAPA. What is DAPA has brought us to? There have been lots of studies. Very important thing that this is the molecule which has more than 250 clinical studies on glycemic control. On cardiovascular disease, there are more than 30 trials. On CKD, more than 12 trials. So plethora of evidence for all different issues which are extremely important to manage our different diabetic patients. And if you just see its glycemic efficacy, it has been studied all different aspects as a monotherapy, as an add-on to different molecules which we are using, metformin, leptin, bio, or SUs, then as an add-on to insulin, then as an add-on to GLP-1 agonist, and also there is a head-to-head comparison with versus glipizide. And how can we forget the landmark trials on both cardiovascular disease and renal disease, declared TIMI, DAPA, heart failure. Then there are real life studies like CBD's Real Nordic, and the blockbuster study DAPA CKD, which was published in October 2020, which brought lots of information and enthusiasm to use this molecule to manage or prevent diabetic kidney disease. Next, please. And many of the studies which we are going to see in the years to come or in the months to come. So DAPA not only has action, but also it works beyond glycemic control. Next, please. And that has been extremely beneficial. This is a snapshot of its impact on diabetes control, and as you can see that it reduces A1C anything between 1 to 2% if we combine with metformin or gliptin or sulfonylureas or glitazone or as an add-on to insulin. So this is a molecule which works along with all the different anti-diabetic agents which are available to treat our diabetic patient, and it has got synergistic action. And because it's having insulin independent action, it works in different mechanisms and which is extremely useful to treat our number of diabetic patients. Next, please. And these are the study on weight. Not only it controls blood sugar, but also there is a weight reduction. And even if we combine with insulin or pioglitazone or glimepiride, which are likely to increase weight, except pioglitazone studies, all other studies have shown that there is a weight reduction even if you combine with sulfonylureas or insulin. And this weight reduction, which are in the pounds, maybe 5 to 6 pounds, there is 3 to 4 kgs, and the last two are in kilograms. Dapagliflozin can reduce weight on an average 3 kg. Next, please. Its impact on blood pressure, it reduces systolic and diastolic both 3 to 4 mm. Next, please. And CVD outcome, Dr. Jayesh Prajapati is going to speak in depth. So just touching a few aspects, this famous Savatini study which showed the importance of dapagliflozin and its use. And first and foremost, it was a very, very large study involving more than 17,000 patients. There were hardly any CV outcome trials which rose 5 figures, that is number more than 10,000. And it lasted for 4 years, and they studied everything, all composite CV outcome as well as efficacy endpoints like composite hospitalization for heart failure or CV death, etc. Next, please. And these were the results. It showed, improvement in cardiovascular death or hospitalization for heart failure. There was also reduction in MACE. There was reduction in renal composite points and death from any cause. All these were significantly reduced, except from death from any cause. The reason was that this study involved both primary prevention population as well as secondary prevention population. Next, please. There was also this study which was done in Nordic countries, that is Scandinavian countries, and this was a real world evidence, which is, in my view, very, very important. Whatever clinical trials we see, whether they are being translated into our routine day-to-day clinical practice, that is going to be extremely useful. So this was a data registry which was done in Scandinavian countries, and there was 10,000 people who received DAPA, 30,000 they received different DP4 inhibitors on an average 1 year duration. What they studied was MACE, hospitalization for heart failure, all-cause mortality, and these were the results. Next, please. Fantastic results. There are reduction in MACE, almost 21%. All-cause mortality was reduced by about 35%. And there was, composite endpoints on hospitalization for heart failure. There were also reductions about 38%. So dapagliflozin patient, they had lower risk of cardiovascular events and even all-cause mortality compared to DP4 inhibitors. And these are the DP4 inhibitors which were used in Nordic countries where Vildas, Sita, and in comparison to all these gliptins, there was a remarkable reduction in all different parameters. And again, this is a very, very robust study, real world evidence involving more than 40,000 subjects. Next, please. And the SGLT2 inhibitor here was seen was dapagliflozin. This study was done in Japan, and they studied dapagliflozin's impact on cardiometabolic risk factors. Again, if there was a comparison with sitagliptin, and as you can see, the A1C reduction was similar, hypoglycemia was similar, but body weight reduction was seen more commonly in DAPA arm than sitagliptin arm, and composite endpoints, which is an improvement in all different endpoints, was seen in a higher number, almost 8 times higher than sitagliptin arm. So dapagliflozin was found to be having impact on improving cardiometabolic risk, reducing body weight, and at the same time keeping A1C normal without increasing the chances of hypoglycemia. The study which was done in Japan. Again, it was a real world evidence. It showed, next please, there are benefits on hypoglycemia and etc. Again, this study which I was telling, a blockbuster study, a landmark study, DAPA-CKD, which has become extremely popular because the results it has brought to dapagliflozin was studied in patients with chronic kidney disease, and very, very importantly, in this study, the patients were both diabetic and non-diabetic, and they were randomized, double-blind, placebo-controlled, multi-center clinical trial, and DAPA was compared 10 milligram and placebo compared trial, and the duration of study was about 2.5 years. And these patients already received the ASN or ARB as per the discretion of the clinician, and the endpoints which were studied were on the development of reduction in EGFR more than 50%, ESKD, renal or CV death. Next, please. And these were the results which were eye-opener, that there was a reduction in cumulative incidence of all these primary composite endpoints, that is reduction in EGFR more than 50%, renal death, etc. 39% reduction in all these composite endpoints. And if you just see the kidney specific composite outcome, there was a reduction of about 44%. And if we see both cardiovascular causes and hospitalization for heart failure, again, there was a reduction of about 29%. And most importantly, the death from any cause, there was a reduction of about 31%. And these were not only death from cardiac or renal, but from any cause. The patient having CKD, if you give dapagliflozin, with or without diabetes, the reduction in all-cause mortality found was 31%, very, very impressive. So regardless of the presence or absence of diabetes, this is very, very vital to know and understand. Without or with diabetes, there was a reduction in everything: kidney disease, death from renal causes, cardiovascular causes, and also all-cause mortality. So very impressive data. Next, please. And the reduction in albuminuria was also seen. It's a very short-term study, and there was a combination of DAPA plus Saxa, DAPA alone, and it was found that urinary albumin excretion was remarkably reduced if you use DAPA, and there is also additional reduction if you use DAPA plus Saxa. Next, please. So these are the comparison of different SGLT2 inhibitors and as a monotherapy or combination therapy. Of course, they are almost equally effective, reducing A1C about 1 to 1.5%, and they have been studied along with all other different molecules, and they are found to be working very well, and they are extremely useful to treat number of our anti-diabetic patients. Just we need to respect the contraindication. Next, please. This is a very busy slide, but it compares the characteristics of the cardiovascular safety studies of SGLT2 inhibitors, ANVAS, EMPA, REG outcome, CANVAS program, DECLARE-TIMI, and VERTIS-CV. So one is on EMPA, second is on CANA, third is on DAPA, and last one is in etroglyflozin. Well, just one or two comments that if you see the DECLARE-TIMI which involved DAPA, it has got 17,000 subjects, and established cardiovascular disease was 41%, whereas in case of EMPA-REG outcome, 99% had established cardiovascular disease. So this is a major difference. And if you see the CANVAS program, again 66%, and VERTIS-CV program, again 99%. So DECLARE-TIMI was the only study which had only 41% established cardiovascular disease. That means 59% didn't have established cardiovascular disease. So they are sort of, garden variety type 2 diabetic patients without cardiovascular disease. So the information we gathered from them is extremely useful because all of our patients are not having cardiovascular disease. What was the impact on patients who didn't have cardiovascular disease? Again, there was significant reduction. This study has been extremely useful and a very guiding force to use SGLT2 inhibitor in patients who are prone to develop atherosclerotic cardiovascular disease or renal disease. Next, please. Again, these are the dose range which we all know very well, so I won't spend time on this. I will go to the next slide. And well, this is a very, very important slide which will definitely give us more enthusiasm to manage many of our diabetic patients in a very positive way in year 2021. What dapagliflozin is or SGLT2 inhibitor is bringing us to, there are three things: that it improves symptoms, it improves survival, or it increases longevity, we can say, and it reduces hospital admissions. So it reduces morbidity, reduces mortality, and it improves quality of life. And there are many studies which are already undergoing, and I won't go into the detail, but one or two things I would just like to say that which are new, and we are excited to know that dapagliflozin is also used in there is a study undergoing on respiratory failure in patients with COVID-19. There is a head-to-head comparison of EMPA and DAPA because there is, there are always we compare that EMPA reduces all-cause mortality, and we don't have evidence for DAPA. So there is head-to-head comparison of these two very important precious molecules, EMPA and DAPAs. So there will be many studies which will come and which will highlight us how best we can use this molecule to treat n number of our patients, even patients with acute heart failure. Dr. Jayesh is going to touch on this. Next, please. So we are very excited with the impact dapagliflozin can have on diabetic patients. It is not only useful to treat diabetes, reduce weight, reduce blood pressure, but at the same time, it also improves cardiovascular diseases, mortality due to cardiovascular diseases, kidney problems, kidney issues, and also mortality due to kidney problems. With this, I would like to end my talk, and I would like to thank all of you for your very patient hearing. And I'm looking forward to hearing from Dr. Jayesh Prajapati. Thank you, Dr. Sanket, for.
Pleasure, sir. I think it was a very lucid presentation. I would request Dr. Prajapati, sir, to start sharing the slides. I would request Dr. Manoj Vitlani, sir, to be the chairperson of the session, sir.
Yeah. Thanks, MacLeod, for organizing this CME. Thanks, Dr. Tiven Marwa and Dr. Manoj Vitlani and Dr. Prakash Kurmi and all. So this evening, we are going to discuss on the dapagliflozin. So now I share my slides. So my slides are visible now?
Yes, sir, we can see your slides.
So we know that the heart failure management, initially what happens in since last 10 years time. So after the glitazone conflicts, any diabetic molecule, they required the cardiovascular safety. And we know that the diabetic patients, they die because of either a coronary artery disease or heart failure or the renal dysfunctions. So while proving a safety, these are the molecule like GLP-1 receptor analog, and another one is this one SGLT2 inhibitors, where they were proving for a safety. Nowadays, they are now beneficially. So now they are considered the molecule not for the endocrinologist, but these are the molecule for the cardiologist as well as the nephrologist. So nowadays we are considering this molecule for heart failure management. And we know that after the DAPA-HF trial, even the non-diabetic patients with heart failure, the drug proven better. So that had the molecule of diabetes now moving beyond diabetes to the non-diabetic people. And there are some of the studies they are undergoing that already Dr. Marwa has shown the slides, that even with the preserved ejection fraction, even the patient who are having a borderline blood pressure, that I'm going to discuss, the molecule has been, is now, some of the data will come in the future. We know that the heart failure incidence nowadays, any cardiologist wants to become, nowadays what happened in the cardio, there are some subspecialties. Previously, before 15-20 years, the cardiologist like myself, we were doing the pediatric, we are doing the adult, we are doing the pacemakers, and we are doing almost peripherals and everything, structural and everything. Now the subspecialties are developing. So anybody new physician or new cardiologist want to develop is a heart failure specialist. So heart failure is the field which is expanding tremendously. See, the new things are happening in heart failure, like the devices, even the newer drugs, even the surgeons, the cardiac transplantations, LVADs. There are so many things happening. Impella device. There are so many things happening in the heart failure. So heart failure is a big thing. And we know that heart failure is the end result of so many things. So diabetic patients, see, the diabetes is one of the important, if the patient has got a diabetes and non-diabetic, see, most of the studies like Framingham study, cardiovascular health study, heart and soul study, all these studies have shown that diabetic, they have got a higher incidence of heart failure compared to the non-diabetic, either a male or female. Another is the kidney disease. Of course, the kidney disease is like hypertension. So many people are unaware and only few are treated properly. The same thing for kidney also. So prevalence and manifest of kidney disease in diabetic and non-diabetic. Of course, we see the tremendous difference. Prevalence of CKD in diabetic patient is high. Nowadays, the longevity of each and every individual is increasing. And then even the diabetic patient, we have seen their life for 20, 30, 40 years. And of course, they will develop a complication related to diabetes. Main is either a cardiac or a nephropathy. So they will end up into the end-stage renal disease. So diabetes and heart failure are the interlinked. So treatment should be directed towards both. So why it is so? So diabetes, heart failure, renal dysfunction is a vicious circle. All are interdependent. So risk factors, major risk factors, when we see the diabetes, atherosclerosis, hypertension, CKD, everything is interlinked. So drugs also affects each other. So it's a vicious circle. See, even the heart failure also in a long run can lead to diabetes, and diabetes in a long run can lead to the heart failure because of sympathetic activation, obesity, insulin resistance, and of course, the hypertriglyceridemia, water retention, CKD. So CKD also affects the heart failure. So it's a vicious circle, kidney, heart, and diabetes, and all these things. So how the diabetics affects heart? Not only by doing the ischemic heart, not only coronary artery disease. So diabetes causes hyperglycemia, insulin resistance, hyperinsulinemia, and that can lead to the that endothelial dysfunction, coronary dyslipidemia, can lead to the coronary artery disease. There are multivessel coronary, small vessel diffuse disease, multivessel disease that is common in diabetic coronary artery disease. That's what we are seeing in our Indian patients, those who are long-standing diabetics. And not only that, some of the patients we have seen the diabetic, they have got a global LV hypokinesia, and their coronaries are normal. So these are the diabetic cardiomyopathy. So muscles are affected. So that is cardiomyocyte hypertrophy or LVH, RAS active, some fibrosis. When we see, it's like a cardiomyopathy. When we see the biopsy, there are fibrosis. So an autonomic dysfunction and or tachycardia and everything, even higher sugar level, glycated end products, and everything in the long run lead to the diabetic cardiomyopathy. Even the coronaries are normal, they have got LV dysfunction. So ultimately they will end up into the heart failure. So how the various molecules, which are the therapeutic approaches? So we know that the heart failure, how we are managing diabetes by giving drugs like insulin. So insulin acts at the systemic level or the muscle level, adipose tissue level. Some of the molecule glutazones, they affect at the muscle level, renal level, SGLT2 inhibitors, even the biguanide. So everywhere the function of each and every molecule, like glucagon, like effect. So the anti-diabetic molecule, they have got a different kind of action. They act at a different level, and they have got a different side effects that we have to keep in mind, and accordingly we have to choose. So these are the various mechanisms of action where SGLT2 inhibitor, there's a various group, SGLT2 inhibitors. Then of course the metformin is like aspirin for the diabetologist. DPP4 inhibitors, GLP-1 analog, insulin, sulfonylureas, and of course the pioglitazones and all this one. So these are the effects of diabetes and how this molecule act, either incretin level, lipolysis, uptake levels, neurotransmitter, and of course when we see all these molecule effect, which are the molecules which are effective and cardioprotective. So number one comes is the metformin, because it's a country like India, which is a cheap molecule. So metformin is like aspirin. So what is metformin? Decreases the mortality in heart failure patient, reduces the cardiac hypertrophy by AMPK mediated repression of this one, and better short-term and long-term prognosis in patient with heart failure. Of course, there are not much mega trials like, but it's a drug is safe for this one. So these are the older molecule that doesn't require CV safety data. What about the SGLT2 inhibitors? Of course, there are tremendous data, and almost most of these cases is a class effect, which almost all four gliflozin we know the empagliflozin, remogliflozin, and of course the dapagliflozin and canagliflozin. So it improves the CV risk factors. It decreases weight. That is one important. Reduces the somewhat 2 to 4 millimeter a millimeter of Hg systolic blood. Improves the lipid profile. And of course, there are reduction in CV safety data and heart failure data hospitalization. So second molecule is a SGLT2 inhibitor. What is the third one? Third one is a GLP-1 receptor analog. No increased risk in heart failure, hospitalized for heart failure. So it's a neutral molecule and modest improvement in ejection fraction and heart failure patient, and CV risk is decreased. So patient having high CV risk and heart failure patient, then of course GLP-1 analog is one of the important things. And then comes what we are using routinely, the sulfonylureas and insulin. So there is no definite CV outcome trial examining sulfonylureas in heart failure have been conducted. Another thing is that what is hypoglycemia. So hypoglycemia is more detrimental for cardiac patient, but of course is a wonderful molecule to reduce the HbA1c and causes some weight gain, while the metformin causes some reduction in weight. What about DPP-4 inhibitors? The DPP-4 inhibitors like gliptins, so vildagliptins and all. So DPP-4 inhibitor, no increased risk in heart failure, of course, but some of these hexagliptin and all, they are got a heart failure hospitalization will increase. So these are the main molecules. And another negative molecule for our cardiologist, if the patient has got an LV dysfunction, then fluid retention and weight gain as a side effect and precludes its use. So pioglitazone should not be used in patient with heart failure. That we should keep in mind. So which are the various guidelines? This is a very busy slide, but has been discussed. So in your seen this slide in so many talks. So only things I'm going to very brief. So of course, see the first line therapy. Sorry. First line therapy is metformin and comprehensive lifestyle. So lifestyle modification plus metformin is the first thing. And indication for high risk established, suppose patient got established ASCVD, CKD or heart failure. Then if ASCVD predominant, then GLP-1 receptor analog or SGLT2 inhibitors are preferred. If the heart failure or CKD predominant, SGLT2 inhibitors are preferred. If compelling needs to minimize the hypoglycemia, then DPP-4, GLP-1, SGLT2 or glitazones, glitazones are preferred. If compelling need to minimize the weight gain or promote the weight loss, GLP-1 receptor analog or SGLT2 inhibitors are preferred. So those patients who are the obese, then of course the first choice will come is the metformin followed by SGLT2 inhibitor or GLP-1 analog. And this is a slide showing according to if HbA1c, you have to add on something like that. So one molecule, another molecule, these are the various groups in this busy slide. This is ADA 2020. And they have mentioned which molecule, liraglutide, they have mentioned in the down, the footers, semaglutide, liraglutide, and everything they have given in this busy slide. Even the ADA ESC update is almost the same thing. If ASCVD predominant, GLP receptor analog SGLT2 is preferred. If heart failure or CKD predominant, then SGLT2 is a preferable then add on. So which are the various data has been based on what? So impact of glucose lowering medication on cardiovascular endpoints, on cardiovascular outcome trials and heart failure hospital from AHF 2019. So these are the various studies. See the ELIXA study. So recent ACS, and they have shown that no difference in risk. So drug is not bad. So LEADER and ELIXA, these are the two leaders, and this is liraglutide. There's no difference. CVD or high risk patient, it is studied around 9,000 patients. So liraglutide based on LEADER trial, another is ELIXA and SUSTAIN. These are the various studies, and it has shown that there is no impact. Heart failure hospitalization not increase. So this is the important thing. And what about the sexagliptin? It's the only thing where the increased risk of heart failure related hospitalization, that is with this one. And another sitagliptin in the TECOS has been studied. There are no difference. So sitagliptin, even the vildagliptin, some data is available. That's why using. And of course, we know the EMPA-REG out.
Dr. Prajapati? Sir, we lost you here. Hello, Dr. Jayesh Prajapati, can you hear me, sir?
I think there is network issue from doctor's side.
Right. Can we have a quick
Dr.
check with him?
Sanket, can we proceed for the questions to answer with the Dr. Tiven Bhai?
Yeah, no problem. Yes.
Yeah, so we if till the Dr. Jayesh Prajapati available, we'll discuss the something with Dr. Tiven Bhai.
Sure, sure. Manoj, you are there, so I'll be happy to share.
we want to hear you. I do not want to ask any questions. You showed very eloquently about the dapagliflozin. But I want to ask about the another determined study and the another study on the determine with the six means with preserved ejection fraction and the reduced ejection fraction, and on the exercise capacity. How do you rate such studies?
Well, honestly, I have not gone into the depth of those studies. So, Manoj, I would expect you to answer your comments.
Oh,
And
I don't know. That's why I asked.
you can ask on DAPA CKD, and you can ask me
Then
on
Dr. Sanket will answer.
Sir,
Sanket.
so these are ongoing studies, sir, and the randomization and the inclusion criteria has been a little strict on these. I think once they get published, we might have some change in practice pattern identified because of the robust data that it will come out with. Currently, it is still ongoing. There are no results that has been shown. I believe we have to wait and watch what comes after.
Recent discussion showing the not focusing on the total cause of death for these all glyphosines, but only the considered as the benefit for the heart failure only, rather than the anything else.
So currently, I mean, till the time we do not have the outcome specifically, we can only mention on the inclusion/exclusion criteria and the sample size that they're looking at.
Now,
And,
Dr. Jayesh Prajapati available. Now,
yes, sir. Jayesh, sir, we can see you now.
Yeah, sorry. Yeah, sorry. I think I have left at what level?
So we were, I wouldn't know the slide number, sir.
Okay. Just I'll show that. No problem.
Sure.
I stop video, so it will be easy. Probably the network issues, so not an issue.
Sure.
yeah.
So I think we were here at that time.
Yes.
yes.
I think this slide is finished.
Yes.
You can go ahead.
Okay.
With the
Yeah, no problem. Okay. So now I'm audible clearly.
Yeah.
Yes.
Okay. So these are the for heart failure hospital. What about the renal? So these are the various molecules for cardiorenal efficacy of newer hyperglycemic drugs in primary and secondary prevention. So we know which are the neutral one, and this is important. So for the primary prevention, diabetes plus multiple risk factors, of course, the SGLT2 inhibitors have shown that the heart failure and of course the kidney disease protection is there. While GLP-1 receptor agonist DPP-4 inhibitors is almost the neutral. So this is the one. So that's why the SGLT2 inhibitors for CKD as well for primary as well as secondary prevention, when we see the DEPA and this DECLARE trial and all these things. So these are some of the case examples I think we are going to discuss with our discussion where the SGLT2 inhibitors to be given. So SGLT2 inhibitors, another important issue after this DAPA-HF trial, the patient with or without diabetic. So when we see the data, even the CANVAS and all other studies, the patient, they were with either with a cardiovascular only risk factors or patient with established cardiovascular disease, diabetic, non-diabetic. So all kind of patient has been studied with LV dysfunction. Even the last with the preserved ejection fraction studies are also undergoing and some of the data has also been published. So what about the kidney? This has already been discussed by Dr. Tiven Marwa. So I'm not going to go in detail of this one for nephroprotection. But of course, the SGLT2 inhibitors, they provide the cardiorenal protection by making weight loss, some of the reduction in systolic blood pressure, decreasing the plasma volume with some little side effects. So, but of course, we have to be very careful if the patient having eGFR of less than 30 or some say up to 50, we have to be very careful that we are going to discuss. So what is the rationale for investigating SGLT2 inhibitors in heart failure beyond type 2 diabetes? So it has got an effect on diuretic effect as well as a metabolic effect. But one thing we have to be very careful that patient if they are starving, we have to be very careful for ketoacidosis. So we have to sometime, it is better we should monitor ketones while the patient on SGLT2 inhibitors. So these are the development history of various SGLT2 inhibitors. So it was 1835. Some of the scientists, they have find out from Apple, but the various studies had been started after the regulatory guidance of the CVOT, the FDA has announced, and then the EMPA-REG outcome has came in 2015, followed by CANVAS, and then DECLARE, and then DAPA-HF, and recently has been published with preserved ejection fraction with empagliflozin. So these are the various studies, and it has shown that these are the with reduced ejection fraction. These are the study. I'm not going to go detail of this one, but these are the various beneficial effects by all this mechanism, and it improves the heart failure outcome. So which are the approved indications? So one thing is very approved indication is type 2 diabetes as an adjunct to diet and exercise to improve the glycemic control in adults with type 2 diabetes and to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes and establish cardiovascular disease and multiple cardiovascular risk factors. Heart failure indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in adults with heart failure with reduced ejection fraction. But one thing is that recently the Canadian guidelines, even the patient with heart failure without diabetes, after DAPA-HF, it can be given after giving, suppose ERNIs, of course, is a choice, and then add on, we can give the SGLT2 inhibitors. Doses, everybody knows that starting dose is 5 milligram orally once daily, and we can increase up to 10 milligram once daily. And some of the patients we have to be very careful. While the heart failure, 10 milligram oral is a once a day dose. What about cardiorenal efficacy? So see about almost all the molecules, the DPP4 inhibitors, GLP-1 receptor analogs, and see the dapagliflozin for MACE-wise, for cardiorenal efficacy. See for the heart failure patient, it is beneficially. So primary endpoint, secondary endpoint, everything has been reduced. While with GLP-1 receptor analog, it is for cardiovascular endpoint, secondary endpoint were reduced. While the heart failure and diabetic kidney disease, it is almost the neutral. While see with the sexagliptin, some of the heart failure hospitalization were increased, otherwise it is a neutral. So our choice will go according to this one. So this has already been studied, DAPA-HF already been, I think, discussed by Dr. Tiven Marwa. So I'm not going to detail DAPA-CKD and all these things. So these are some of the small study, derived study. Also, this is for the renoprotection, all these CKD patients. The renoprotective effect dapagliflozin for urine albumin creatinine ratio and all these things. So which are the important studies that going to, what is the future of dapagliflozin? So dapagliflozin does what really wants any drug to do, improve the symptoms. So pump pipes and filter. So everywhere it affects. So dapagliflozin preserve ejection fraction in heart failure, DAPA with heart failure readmission. Another important trial is the DAPA and effect on cardiovascular event in acute heart failure in thrombolysis and myocardial infarction. This is one of the good study. And another head-to-head comparison between DAPA and EMPA. And of course, the efficacy, acute heart failure. Nowadays, we are avoid this molecule in ICU setting because of hemodynamic instability. But this is one study going in acute heart failure. DAPA in diabetic patient with decompensated heart failure. This is also one important thing. And of course, Dr. Marwa has told in COVID-19, another is that patient after giving the ERNI, there is borderline blood pressure where we cannot step up the ERNI. Suppose what happened? What in India we are practicing? patient, we are usually trying the costly molecule later on when he doesn't improve with all molecule. So blood pressure is 100, we have given this Ernie and the blood pressure is around 96 or 100, then we are not going to increase Ernie. But whether we should add DEPA or not, that comes in our mind. So these are the dapagliflozin, hypotensive heart failure patient after Ernie, that will be another answer. So these are the study. So that future of the DEPA may be bright after this initial data. So dapagliflozin will bridge the gap. It is recommended by reputed bodies and almost most of the guidelines, ADA, ACC, in the management of type 2 diabetes with ASCVD, heart failure or CKD for reducing the hypoglycemia and weight gain. And more than 350 completed trials and 80 ongoing trials have proved the role of dapagliflozin in glycemic control and beyond. And landmark CVOT trials like DAPA-HF have shown survival benefit heart failure with or without diabetes. And of course, the first and only FDA-approved SGLT2 inhibitor in patients with heart failure with reduced ejection with and without diabetes. No other SGLT2 inhibitors to reduce the CV death in patients with heart failure with reduced ejection fraction with and without diabetes. So future is very bright. So if we clear us pump, pipes and filter, so kidney, heart and glucose, everything will be benefited. Thank you so much.
Thank you, sir, for the lucid presentation. I would request the audience to share their questions in the chat box. And if Dr. Vitlani, sir, you were discussing a few points on the cardiovascular aspects. I think now it's the
Yes.
time to get into the discussion, sir. Over to you, sir.
Okay, Dr. Jayesh Prajapati told pump, pipe, both. Is SGLT2 at present world over? Everybody talks about the only for the pump rather than the pipes. I don't know what is the opinion of the Dr. Tiven. I considered only for the pump rather than the, because at present scenario in diabetes means all August recently completed the many international conferences also said that the usefulness in the type 2 diabetes with heart failure or without the diabetes. Heart failure, SGLT2 inhibitors considered as a anti-heart failure drugs after the use of the ARNI. Rather than the, for the pipes, I don't think so. It is that hyped much.
Well, I think the studies have already shown, if we see all these three studies, EMPA-REG, CANVAS program, and SEVERTIMI, particularly the two first studies, because they were involving mainly the patients with having cardiovascular disease. So there were distinct reduction of 3-point MACE, which included cardiovascular mortality, myocardial infarction, and stroke. Of course, on stroke, there was a non-statistically increase in number in EMPA-REG trial. Others were neutral. So there is definitely impact on pipes also. But you are absolutely right. The absolute vigilant effect which we can see on pump, they are not as much clear-cut as we see on the pipes. But there are clear-cut indications that this is also useful on the arteries, and that's why it has, indication for atherosclerotic cardiovascular disease. On the other side, if we, dissect the guidelines which are published for 2021, they have separated heart failure indication. So for heart failure, they clearly mentioned that you should focus on SGLT2 inhibitor. But atherosclerotic cardiovascular disease, you can use either SGLT1 agonist or SGLT2 inhibitor, depending upon the eGFR. And also if there are renal complications present, then again, this SGLT2 inhibitor can be a preferred molecule. So in totality, barring patients with very low eGFR, SGLT2 inhibitor are going to be useful for all these three indications, I would say. If I had to put in the hierarchy, heart failure, renal problems, and lastly, cardiovascular disease.
Yeah. So I agree to your point. Of course, there are some controversy for the stroke, as you have mentioned. That something like that in empiric outcome, the stroke incidents were increased, while in the canvas was a different thing. There was a more incidence of amputation and all these things. While in the dapagliflozin, there are not such things increase in the stroke. But of course, for cardiovascular protection, they say that GLP-1 analogs, and second they mention the SGLT2 inhibitors. But the GLP-1 is available in India.
Yeah.
Yes, of course.
Okay.
And they are currently injectable, but in 2021 we will have oral GLP-1 also, semaglutide. So
Okay.
currently they are injectable, so that's an issue that, and they are costlier. So these are the two problems.
So of
But
course, then
Deven bhai, I want to ask you, if only the pipe problem, GLP-1 is already more favored compared to
Yes,
insulin.
of course, the results are more favorable for GLP-1 agonist, but there are two problems. Currently, they are injectable. We don't have semaglutide, and secondly, they are much costlier than SGLT2 inhibitor. And there are other molecules which can improve the pipes, like or antiplatelet agents. So we can offset the cost benefit by not using GLP-1 agonist as a main agent to prevent pipe. I would see in totality. But I agree, if there is a problem of ASCVD, which is predominant, we are having more, evidence for GLP-1 agonist, particularly liraglutide or semaglutide, and even for that matter, dulaglutide, rather than SGLT2 inhibitors.
Yeah.
Just an announcement. Sorry,
Yeah.
sir. Just an announcement to make for the audience, because we have a good set of audience, and currently we do not have any questions in the chat box. I would request the audience to put whatever questions they want to ask the panel in the chat box, and we would be happy to take all of them during the session. Over to you, sir. Jay, sir, you were saying.
Yeah. One thing I want to ask, patient who are, of course, most of the patients with coronary artery disease, they have got a heart failure also. And we have got a easily availability of SGLT2, which are the orally available. But what about the ICU setting? Patient having MI and diabetic patient, then you give GLP-1 because we have not got much experience with GLP-1. So in ICU setting, which is your molecule of choice? Because we are not giving the SGLT2 inhibitors. Sometimes creatinine is borderline. We are not giving to metformin. We rely always on insulin. So which are the second options for the drugs? I want to ask Dr. Marwa and Dr. Clark.
Well, I think, yes, this is not the case where we should initiate GLP-1 agonist. And for that matter, even SGLT2 inhibitor. The safest molecule is insulin. And there are some studies which are going on for DP4 inhibitor, which we can start in ICU. But before patient is getting discharged, now there are studies which show that we can start SGLT2 inhibitor if there is dominance on heart failure, so that you can see what is the impact, and also you can see the cardiovascular stability, particularly blood pressure, etc. But we must not start in ICU. So for ICU, insulin for all diabetic patients, because there can be side effects which can be detrimental to the outcome in a given individual having cardiac problem. Manoj, your comments.
Now you are absolutely told exactly right. I always prefer the insulin in ICU. Yeah. ICU setup, no other than the insulin to be thought of.
Exactly. You should not think anything else than insulin.
And what about the creatinine clearance? What level you feel safe to give the SGLT2 inhibitors, and another one, which one? At a lower, suppose eGFR between 30 to 45 or 45 to 60, whether you prefer EMPA, DEPA, or any specific choice or not at all. And what about the DPP4 inhibitors?
Well, for DPP4 inhibitors, well, there are no problems. First and foremost, we should see that two aspects, efficacy and safety. Fortunately, even if you give these molecules when they are not going to work, there are no safety issues. Although there are now studies which show that if you don't give an appropriate dose related to kidney function, there can be side effects seen with DP4 inhibitor. Large Korean studies have shown that if you don't match according to the renal function, there are likely some side effects. So far, we were believing that we have to adjust DP4 inhibitors according to EGFR, but this is only to not to waste the medicine, but there are no side effects. You are not going to gain any benefits, additional efficacy, which we can see with insulin or sulfonylurea. But only thing we need to reduce the dose, and that is also true for only sitagliptin and vildagliptin mainly. For teneligliptin and linagliptin, you don't require to reduce the dose. But there are not side effects. But there are some studies which have shown that if you have not reduced the dose according to EGFR, for example, for sita and vildagliptin, there can be side effects. Now coming to SGLT2 inhibitor, unfortunately, DP4 inhibitor is going to work even with the end-stage renal disease, even patient with dialysis. SGLT2 inhibitor is not going to work in patients with lost kidney function. And if EGFR, now there are studies up to 25, and DAPA is recommended up to 25, but below 25, since there are no nephrons, SGLT2 inhibitors are not going to work. But fortunately, there won't be side effect. Now, question arises whether these patients who are having very reduced EGFR, giving them SGLT2 inhibitor, whether we can provide them benefit on heart, which is also very important, that needs to be studied and answered. So, in nutshell, the answer is SGLT2 inhibitor, they don't work after certain EGFR, which can be 30 or 45. But they keep on working for other aspects like heart failure, etc. But as an anti-diabetic, they don't work and they lose their efficacy. Whereas DP4 inhibitors can be given till the end-stage renal disease. Only some of them would require change in the dose, but linagliptin can be given in the same dose till the end-stage renal disease.
Yeah.
Just a little to add to the same topic, sir. It is about the DAPA CKD. It says it was a kidney protection, but for the first 22 weeks, there was a fall in GFR and then the GFR raised. So probably even at GFR about 25, it did work, but the initial days are very crucial, and later you get the benefit of protection, which the DAPA CKD mentions. Sir.
It prevents the further decline of the EGFR after the first 3 months.
Right, sir. Right, sir. So we have a question in the chat box, sir. We have insulin and SGLT2. Who will win the race? I think the question comes with the background that the ones who are now prescribed SGLT2 require less of insulin dose or a delay in the initiation of insulin. What would be your comment, sir? I would request Dr. Prakash Kurmi, sir, to share his opinion. Dr. Prakash, you are muted right now, sir. If you can just unmute yourself. Sir, we
Yes,
can hear you.
definitely. I would like to say that SGLT2 inhibitor, they have definitely advantage over the insulin. So coming time, I think it will be more useful. But I think still the clinical experience of the so many patients we will like to have for giving our clear-cut opinion on this.
Thank you,
What
sir.
about Tiven Marwa, sir? What do you say, sir? I think you have more experience of it.
Well, both are irreplaceable. You cannot replace insulin with SGLT2 inhibitor, and at some places you can't replace SGLT2 inhibitor with insulin. On the contrary, we have to respect insulin enormously. It is horses for the courses. So why I'm telling this, because there are now a lot of thrust on use of SGLT2 inhibitor for several reasons. Unfortunately, people say that this is a replacement of insulin. It can, in some patients, yes, it can delay the use of insulin, but it must not be abused or overused. patients who are having real insulinopenia or insulin deficiency, if you use SGLT2 inhibitor, it can precipitate side effects and it can lead to euglycemic diabetic ketoacidosis. Dr. Manoj Vithlani has seen many patients and it can be fatal also. So one should not be overzealous or over enthusiastic in using SGLT2 inhibitor where insulin is really needed. And on the other side, when there are some patients who are on insulin and if their kidney function is good, if they are not lean and thin, by adding SGLT2 inhibitor, you can cut down on insulin requirements. And some of the patients, you can delay the use of insulin. So you have to be very smart and careful and very wise and judicious to use the right molecule in right person. And also you need to use the right combination in right people.
Sir, do you think that in coming time, SGLT2 inhibitor can replace the sulfonylurea?
Well, yes, so far all these studies are done to replace sulfonylurea only. Was it DP4 inhibitor or GLP-1 agonist or SGLT2 inhibitor? As a second line, they wanted to take the place. Sulfonylurea must be displaced because it is a very old molecule, and after metformin, we need something else. And what else we can give? So all comparisons were against sulfonylureas. For DP4 inhibitors, it came that DP4 inhibitor doesn't cause hypoglycemia, it can be used. Pioglitazone came, it can improve atherosclerosis. Then this GLP-1 agonist again reducing weight and also atherosclerosis, and now SGLT2 inhibitor, not only a good anti-diabetic drug, but multiple benefits on kidneys and heart. I'm most impressed with its impact on kidneys, I would say. And as there was Dr. Prajapati highlighted one study where there are 40% of patients, they are having kidney problems, and 9 out of 10 they don't know. And not only the patient knows, but also the physician doesn't know that his diabetic patient is suffering from CKD. So if we are having a molecule which can use the progress of CKD, which SGLT2 inhibitor is doing, it can be extreme boon for the patient. But for that, we need to have, we need to be very proactive in searching for early kidney disease, and we need to treat such patients with SGLT2 inhibitor, which can be enormously useful. So I think my choice or preference for this molecule on two grounds. First, to prevent CKD, which we are having lots of patients which we might be forgetting. And secondly, when they develop cardiac problem, then to prevent heart failure.
Very rightly said, Tiven bhai. One should have an obsession to find out the CKD and the CLD.
Correct.
If you have such obsession, then you never miss the CKD and CLD.
Correct. And there are studies which have shown also that SGLT2 inhibitor can work on NFLD.
Yeah.
And 4% of diabetic patients, they are having NFLD, which are also missed. And this also lead to end-stage hepatic problem, cirrhosis. So this drug is working on diabetes, weight, kidneys, heart, and liver. So it's a comprehensive medicine. But all said and done, we must not forget the side effects and contraindications. And we should not be overboard to choose the right molecule. And we can't, even the diamonds, if we wear for the entire body, we can't, cover our body. We need clothes. So we need simpler things also. So we need to be very careful. The information we are getting or knowledge we are getting, we need to apply appropriately. Otherwise, Dr. Manoj Vithlani has seen many patients in ICU with euglycemic diabetic ketoacidosis. I have seen some patients with hypertension and fracturing at the hip. I have seen patients with genitourinary infection. So, of course, we must not be pessimist, but we must respect the side effects and contraindications which are seen through SGLT2 inhibitor.
So on very similar lines to what you were just mentioning, there's a question which says, what care should be taken by the upcoming physicians while prescribing dapagliflozin for the first time?
I think I already answered some of the things. again, it should not be used for each and every individual. We have to be selective. Indications are very clear cut. There are compelling indications and then there are optional indications. So we have to respect those indications, and we have to see that these patients are not given to lean, frail, elderly patients, having sicknesses, patients with history of repeated urinary tract infections, patients with severe insulinopenia. So those patients must be put aside, and we have to be, proactive in searching if they are having the cardiac or renal problem underlying, and then accordingly we should, add medicine. And when we add this medicine, we should also see what the prescription they are having, and we need to modify so that person doesn't develop severe hypoglycemia. And the side effect profile, like genetic urinary infection, we must explain to our patient what are the chances of them getting urinary infection and how they can. So these are the precautions I would ask the patient. But only one thing, if we can avoid that in elderly senior people, lean and frail, who are more likely to have insulinopenia, and just to avoid the use of insulin, we should not start this molecule. That factor, if we keep in mind, we can save many patients developing some serious complications.
Thank you, sir. Dr. Jayesh Prajapati, sir, I would like to ask you the question which goes towards like what were your observations when you have given dapagliflozin to a heart failure patient for the first time over and above the standard of care? Sir, your opinion, your comment on it, sir.
Yeah, of course, when we give the SGLT2 inhibitor, we have to assess the volume status of the patient. Patient must not be too much dehydrated. So we have to adjust. Once patient is volume loaded, we are giving diuretic. And what happened in clinical practice, we are not reassessing the diuretics. So what happened once we start with Ernie and all these molecules, once the patient become dry, and then we have to adjust the dose of the diuretic accordingly when we use the SGLT2 inhibitors. So that is one of the important things when you give in heart failure patient, where the polypharmacy, we are giving multiple medications. So that is the important thing that we have to keep in mind, an electrolyte imbalance when we use or when we combine all these molecules. That is I want to say.
Sure. Thank you, sir. Dr. Vitlani, sir, I would like to ask you, like recently, liraglutide has got its approval for weight loss, even in adolescent. And SGLT2 also promotes or supports weight loss. So do you think tomorrow for the young diabetic patients who are going for reversal by lowering their weight, SGLT2 would be a right fit at in the pre-diabetes or early diabetes, sir? What's your comment, sir?
At present scenario, SGLT2 do not have a compelling evidence to use in a pre-diabetic patients unless patient having the SCVD. If there is no SCVD, there is no compelling means just for the weight loss. Weight loss is an added advantage. So SGLT2, if there is no compelling evidence for the either heart failure, CKD or ASCVD, in pre-diabetic patients with obesity, I would not like to use. There are as the Dr. Tiven Bhai rightly said, there are some evidence for the usefulness for the NFLD, non-alcoholic fatty liver disease. This is, but till we have to wait for the future trials and the 100% evidence.
Thank you, sir. Dr. Prakash Kurmi, sir, there is a question for you in the chat box. I see is how to overcome fear of genital infection from a patient's mind.
See, routinely before prescribing this molecule, I think we all are taking care that patient has no any active symptoms of any urinary infection. So we have to ask the patient, we have to check it also. And if we are doing it rightly, then ideally in normal patient, there is no much fear of developing severe or such infection. So I think first time whenever we prescribing this molecule, as Tiven Marva sir rightly point out so many things. So we can avoid that complication with the right use of these molecules.
Thank you, sir.
Steven Marwa sir, I also asked that just Dr. Vitlani has rightly said that this is an added advantage of weight loss in this molecule. So only in a diabetic patient we have to use it. But some of the patients, if they are pre-diabetic or having some family history, but HbA1c or any other criteria, they are not fit into the diabetic patient, then in such patient can be used for just as a weight reduction.
Well, there are some colleagues, they are using SGLT2 inhibitors to promote weight loss in obese patients without diabetes.
Okay.
But we need to have good clinical studies, and I just wonder, I saw many studies which are highlighted, which are in the pipeline or which are ongoing, why there are no studies on obesity without diabetes. This is one. If there can be studies on dapagliflozin in diabetic or non-diabetic CKD, diabetic or non-diabetic heart failure, why there can't be study in diabetic or non-diabetic obesity? Well, one of the reasons that it helps lose weight about 4-5 kg only, or maybe 3 kg. And there is some adaptive increase in appetite through glucagon. And it's possible that in non-diabetic person, there might not be as good weight reduction as we seen in a diabetic person. And since there are no other benefits, unfortunately, there are no trials currently going on. But anecdotally, many of our colleagues, they've used SGLT2 inhibitors, and in fact, some are doing sort of observational studies on SGLT2 inhibitor in obese non-diabetic person. And I'm sure that in a year or so, we will have some observational study which will guide us whether we can use this molecule in patient with obesity without diabetes. And of course, these will be very young people, so there won't be any side effect issues like renal problem or for that matter, hypotension, etc. But it looks very attractive proposal what you are contemplating.
Right, sir.
So there is a question in the chat box, a little lengthy and but crisp question. It says dapagliflozin is currently approved for diabetes mellitus as well as for non-diabetic patients. It is the only SGLT2 with a wide variety, and now with DAPA CKD and DAPA HF trials, do you feel DAPA has more benefits, which is balanced amongst the SGLT2 inhibitors? What's your opinion, sir? Let's start with Dr. Vitlani, sir. What's your comment on this, sir?
DAPA for DAPA HF and DAPA CKD.
So is DAPA has like currently DAPA has the widest indications, it says, and it says that the trials are also varied and in multiple sects, in multiple organ dysfunctions. Do you see DAPA is having more benefits amongst the class and is kind of balanced in its approach to as an SGLT2?
For heart failure and CKD, both have a cardio renoprotective, even in non-diabetics. So this is proved for the EMPA also, EMPA CKD and EMPEROR heart failure trial with reduced ejection fraction we have. So as a pump failure and the renoprotective, the most of the, and the, even canagliflozin also, all three have a good efficacy. For the DAPA, one advantage, they have a primary prevention for the heart failure and the primary care patients also, those who do not develop a SCVD in a main declared TIMI main trial, okay, main landmark trial. So that is considered as an added advantage compared to the other EMPA and CANA. So for the non-diabetic, we have a evidence with the all three molecules.
So you feel DAPA is equivalent in amongst the class?
Equivalent for the heart failure patients.
Sure.
And these we do not have a total benefit, total reduction in the cause of death, means mortality, that cardiovascular reduction and CV death. That is the only EMPA is having, that not with the DAPA. This is a clear-cut difference. But DAPA have evidence that they have included a primary prevention patient. So this is an advantage. Those patients who do not have a SCVD, where and diabetic patients, these patients have a definite advantage for the DAPA.
Thank you, sir. So your comments, sir, Tiben, sir?
I think Manoj covered everything, but as you already highlighted, that DAPA has got lots of studies to support it. Right from primary prevention to secondary prevention, from diabetic to non-diabetic, and each and everything. So the span or spectrum it is covering is huge. The only negative thing what EMPA has shown that there is an overall reduction in mortality is not so visible or palpable with DAPA. So still we can't say that DAPA is spearheading and that is the only molecule which is working so well. We have got sufficient evidence from EMPA and canagliflozin. But what is most impressive was this DAPA-CKD and DAPA-HF trial, which has shown that this molecule is working independently of diabetes, both for heart and kidneys. That I found very, very impressive in comparison to EMPA or Cana. And that's the reason why it got FDA approval to use in both diabetic and non-diabetic patients with heart failure. So that is an added advantage on DAPA. And second advantage, of course, that it is also covering primary prevention subjects.
Dr. Prajapati, any comments from your end?
Yeah. I take other way around. It's a class effect. I can say it's a DAPA, EMPA, and it's a class effect. Some here and there, some of the differences are there, but still some controversy, some explanations are not there. Of course, the diabetic versus non-diabetic patient has been also included in empagliflozin with preserved ejection fraction. So there is no head-to-head comparison. So it is very difficult to say which molecule is better. But most of the people, they agree that all these three molecules which have been studied, it's a class effect. When we see the hazard ratio, that's somewhere here and there, some of the inclusion criteria, exclusion criteria, so somewhere variable. So it is very, very difficult to say. It's like a NOVAC. So same thing applies here. So I consider it as a class effect. But some come early, then this is like that. They included guideline after 1 or 2 years, everything will be the same. So guideline even also sometimes mentioned here and there. So when we see all, what's your opinion, Dr. Tiben?
Well, yes, I already answered that. Yes, definitely class effect, and DAPA has been studied very well in certain aspects. So there are some impressive results on that. EMPA is studied absolutely in patients with cardiovascular disease, and it reduces all-cause mortality. So if patients are having cardiovascular disease, it can be a good molecule to increase the longevity. And then there are other studies which have shown that these molecules can be good for diabetic and non-diabetic patients for heart failure. So of course, there is information, and nowadays we work with the evidence-based medicine, and approval are taken with the evidence. That's the reason why DAPA has got this slight additional advantage of using it in non-diabetic heart failure patients as well indication. Otherwise, I agree with you that this should be a class effect only. But since we are having evidence and we are impressed by the evidence, currently we would like to, at least use this molecule in non-diabetic persons having CKD or heart failure. And there are studies which are going on to DAPA versus EMPA head-on trials, and I don't know when they are going to get published, but they will, clarify whether one is superior to other.
Thank you.
Dr. Prakash Kurmi, sir, your opinion, sir.
I think both have clearly mentioned everything. And as far as my view concerned, in my area, because of some economical problem, till now I have not used much dapagliflozin. In very few patients I have used. because of the lower socio-economical class of the patients I am seeing in my practice. So it was very difficult to use this previously, but I think in coming time, I can use it more frequently in so many patients.
Great, sir. So before we end, I think it's already 10 o'clock. I'll just take this last question and we shall close the meeting, sir. The question is, when should I add DAPA? Before gliptin or after gliptin? And before glimepiride or after glimepiride? What would be your opinion, sir? We'll start with Dr. Tiven Marwa, sir.
Well, I think we can continue to answer this question for 2 hours. So this is a very difficult question to answer. But in just 2 lines, yes, again, it's very, very different setup of patients. So what are our priorities? Depending upon those priorities, we can use. But this molecule, as it reduces weight, blood pressure, and prevent renal problems, this can be a good drug of choice after metformin for many of our patients. Sulfonylureas are very, very inexpensive. We have got experiences of years together. DP4 inhibitor is the most benign anti-diabetic drug we are having in the world. Almost zero side effects. So if I want to go very safely after metformin, I might use DP4 inhibitor. If I want to have other comprehensive benefit, I might use SGLT2 inhibitor. If I get a poor patient, I will use sulfonylurea.
Perfect, sir. Dr. Vitlani, sir.
I always go through the compelling evidence when even European Society of Cardiology recommends if there is a compelling evidence is present, whether there is ASCVD, heart failure or CKD, then even you can use the SGLT2 before a metformin. So what, as rightly said, what are your patient characteristics? Patient's characteristics is matches with the first use of the SGLT2, then even after the metformin, you can choose the SGLT2 or both simultaneously in a drug new patient also. If there is HbA1c high more than 7.5, metformin alone cannot be possible to reduce less than or equal to 6.5. So best to use the 2 molecules together if there is compelling evidence is present. Otherwise single. Then when you ask for the sulfonylurea always one step below first metformin, then either SGLT2 or gliptin, and then add on to the sulfonylurea if required. And if there is a patient, frail patient, old age patient, then one should not use this SGLT2. You have to see the compelling indications are present or not. So each and every patient of a diabetic should be evaluated for the SCVD.
Thank you, sir. Dr. Prajapati, sir, your comments to this final question.
It's a like as Dr. Vitlani has told and Dr. Marwa has told, it should be as per already the guidelines. They have mentioned that the compelling indication, like any antihypertensive medications. Only issue is that which one is to be given first. Where I somewhat either a metformin, only one molecule is to be given, then probably I'll go for a metformin, and second choice will be a SGLT2 inhibitor, followed by DPP4 inhibitor. But if the patient having a HbA1c is very high and I want to reduce my sugar level, then the potent drug or cost is an issue. Of course, with the generic dapagliflozin, cost is not much issue. But if the HbA1c is very high, I want to bring down the sugar much more faster. Then, of course, if the hypoglycemia risk is not that much, then of course this sulfonylurea one of the choice. Another issue why metformin first issue that I have seen, I have not seen much patient with SGLT, but whatsoever 2 or 3 patient I have seen with very bad genitourinary infection, one with resistant UTI. So when we see the side effect profile and our Indian patient hygiene and all these things, when one molecule is to be given, then probably I start with a metformin, and second choice will be according to the guidelines as Dr. Vitlani and almost all the guidelines says.
Great, sir. Thank you, sir. Dr. Kurmi, your comments, sir.
Yes, I will agree with all of 3. But what different situation I am facing in my area, because I am seeing so many patients, they are taking the anti-diabetic patients very regularly, either from one of the center who are giving it freely. There are so many centers, they are doing social services. And also some of the patients I am seeing that they are taking the regular tablets from any government setup or corporation setup. In that setup, only metformin, sulfonylurea, particularly either glimepiride or any other molecule sulfonylurea, which is cheaper. So many patients, they are taking regularly only metformin and sulfonylurea. But sometimes I am seeing that even if they are taking regularly, their sugar is not being controlled. So they are coming to me, and I have only best second option, which is cheaper till right now, it to add gliptins, which is very well effective. And as Dr. Steven Marwa said, it is very innocent molecule. There is almost no side effect, and it is cheaper, and it is not available in any government setup. But now we have third option also, this SGLT2 inhibitor. In coming times, we can use more with so many patients. So same, first metformin, second gliptins in my setup, and third I will in coming times I can use in selective patient this SGLT2 inhibitor.
Perfect, perfect, sir. I think we are towards the close of the event. So I firstly thank each and every speaker and chairperson to be actively, in an interactive format. We discussed the topic for diabetes as well as in the cardiology perspective. I think the listeners would have gained deep insights in managing the patient better using the learnings from this session. We at McLeod's would like to honor the vast experience and your kind heart to share the same on such a platform for the benefit of all the current and the future listeners. Today, we also would like to acknowledge a great set of audience which is present today, sir. I would like to take the opportunity to thank each and every participant attendee who had taken time out from his busy schedule and have respected our invitation to be a part of this scientific feast. I, Dr. Sanket Nevale, representing medical team at McLeod's Pharmaceuticals on behalf of the marketing and the sales team, I would like to thank you for supporting us in this scientific endeavor. And I request each and every participant to share your experience and if your feedback with our sales team accordingly, sir. I thank each and every one of you, and I wish you a great evening ahead. Thank you, sir.
Thank you.
Good
Thank
night,
you.
everybody.
Thank you.
Thank you, sir.
Thank you.
Thank
Aarti, we can end the meeting now.
you, sir. So I am ending